Well, first, I'd like to thank InterSystems for inviting me to come and share our work today. It's been a collaboration that's been going on for the last year and a half or so. Um, and so I'm actually hopefully bring a bit of fresh air to the meeting today since genomics is not well represented here this year. I hope that would change over the next year or two as it becomes even more mainstream than it is today. So I speak from the perspective of molecular pathologists. We actually practice clinical genomics in our laboratory, particularly for cancer genomics. And so I'd like to give you our experience of working with InterSystems over the last year and a half to 2 years. So we do apply next generation sequencing for our patients, cancer patients. We test about 4,000 to 5,000 patients per year using the latest sequencing technology. Our experience so far in the last 3 years has been genotyping over 5,000 unique patients in terms of next-gen sequencing, and we do have quite a bit of their data in terms of the medical record, their outcomes, the treatment, and whatnot that are captured in the EMR. So what we've been exploring with the InterSystems HealthShare product is, can we actually merge the two data sets, the genomics information alongside with the clinical data, and with the purpose of generating new findings, new models and relationships that can better help decision support for oncologists who are using our clinical genomics information. So I'd like to take a step back and just describe to you what usually happens with a cancer patient. He or she would show up in the clinic with some finding that is suspicious for cancer. You perform all your routine clinical workup, radiology, et cetera, and ultimately routine pathology is performed in terms of getting a piece of tissue that you would send through a histology lab and then make a histological diagnosis. Today, it's not sufficient to just stop right here because you should send that same sample to a molecular pathology laboratory. There are additional tests and studies done at the molecular level in terms of using next generation sequencing that you should perform on the patient sample because it will give you a highly specific signature. One that in lung cancer, for example, about probably 30 to 40% of patients could actually benefit from this signature. An example that I have is ALK rearrangement in lung cancer. I would say 5 years ago, these patients would die likely within 6 months to a year. Nowadays, if you have an ALK rearrangement found by genomic testing, these patients can live on for 5 or 10 years, which is sort of unheard of in the field of lung cancer. And that's because of benefiting from genomic findings and testing. But genetics and genomics in general for cancer is quite complex. You have a lot of things that happen underneath, whether it's a copy number change, insertion deletion, a point mutation that can happen. And in our lab, we focus a lot on rearrangements as well. So these are two genes that aberrantly come together to form a new fusion gene and protein, and that's the driver for the cancer. So the ALK example I mentioned to you about is one of those examples. There's also protein, gene expression, epigenetics that are quite complex. So the data set for genomics is quite complex when you look at the details underneath. Despite the complexity, I would say 5, 6 years ago, we weren't in a position, the technology wasn't quite ready for a clinical lab to adopt this. It was mainly in research settings. But nowadays, the scaling of technology in terms of next-gen sequencing allows you to even test for a whole human genome sequencing within, say, 27 hours and be able to get that data back analyzed. So yes, today, clinics are prepped and ready to use next-generation sequencing to actually affect patient therapy and patient management and outcome. And so that's what we're practicing today. So if you take a step back and look at the whole workflow, at MGH, this is how things happen. An order comes in for molecular testing or genomics testing. You have a sample that's submitted, some pre-analytical steps that are performed, and then in the wet lab, the technicians are actually taking the tumor tissue, grinding it up, extracting the DNA, the RNA, and then making a sequencing library out of that. Once the library is ready to go, you put it onto one of those instruments that I mentioned to you about in this graph right here, and over, say, 29 hours, it will be sequencing millions and millions of reads per patient. You can't just take that raw data and look at it. It's not human readable. It's just A, T, Z, and Gs, 4 bases in terms of encoding. So you need a robust bioinformatics pipeline to actually analyze that data. And so for us, the primary analysis actually is performed on a cluster. We have 18 compute nodes with dual, I think, octa-cores or dodecta-cores that are running in parallel, about 5 hours worth of analysis. And in the end, it balloons out to be about 30 gigabytes of data that are saved in terms of the analysis. Over the last 3 years, in terms of performing testing for 5,000 to 6,000 patients, we've actually accumulated 300 terabytes of raw data from next-gen sequencing and analysis. So there's a lot of information. So when you talk about big data, this is definitely one of the fields clinically that actually needs help in terms of data management and analysis. Essentially, what comes out of the primary analysis will be a variant, a list of variants. It could be tens of thousands, if not 50 or 60,000 if you're talking about exome sequencing, whole exome sequencing. The variants are stored in our lab in a database. Then I, as a molecular pathologist, would go in and actually interpret the information. I would say out of these 10,000 variants, these are the likely 2 or 3 after heavy filtering, applying some biology to it, and I say, these are the 2 or 3 that are most pertinent for my patient who has lung cancer, or for this patient who has brain cancer, and that is in a clinical report right here. So today, normally we stop at this juncture, but I think we can do a whole lot more. In that there is decision support that the clinician needs, oncologist needs. It's not sufficient enough just to return to say, this is the variant your patient has, is of this tumor type, and maybe there is a drug that might, I think there's way more information out there that we could capture and return back to the oncologist at point of care to help them manage the patient. But once the clinician actually receives that information, they do perform some action or intervention, and then there is some outcome thereof because of that. This is something that we currently don't capture right now, and should we have the capability to capture it, let me skip this slide for now, we can actually feed this new knowledge back into our system in terms of a learning environment to actually better the next patient. So as you accumulate 50 patients with the same mutation, 100 patients with the same mutation, and you're actually following their clinical outcome, you can actually capture all of that back in and develop some model that could actually be reused for the next patient and benefit them. And that's what most places don't do quite well right now, because I believe there are no current solutions for this. And this is where HealthShare comes in. But let me take a step back and tell you what an example of a variant from mutation calling looks like. So it looks like a lot of gibberish, right? Not very human readable, but I like to show this slide because this is just telling you that genomics information is actually very discrete. So if you actually peer into here, this is a semicolon delimited list of key value pairs, highly, highly structured. It can tell you exactly what chromosome the mutation's on, what position, what is the reference base, what is the alternate base. It also tells you what gene, what amino acid is changed, et cetera, et cetera. So on any given day, I would prefer this information versus a clinician's note. Because the notes that we deal with in oncology are 5 to 6 paragraphs deep, buried with lots of narrative notes. I guess clinicians like to write novels when they're looking at patients, but this is way easier to compute on, right, in terms of analytics and machine learning versus clinical notes. So that's the challenge that we have in terms of trying to set up an analytic system for that. So if you take genomics and pair it with clinical data, and that's our proposal, is that we're going to use the HealthShare information, a system that's well known for health information exchange, to accumulate all of the clinical notes, the laboratory values, the radiology notes, the follow-up, the treatment, the therapy, but in the same system, we're actually going to put in the variants as well. And we have actually worked over the last year and a half to actually spec out how do you store this type of information in cache, and we've actually been able to do that. So for one patient, we have about 10,000 variants that are able to be ingested into cache and represented back out via DeepC for analytics. So we've done that step. The next step right now is we're actually taking the CCD for the patients and inside the same HealthShare instance, putting it alongside the genomics results. And that way we have everything in one place for the analytics that we're going to perform. And what is the analytics? Essentially, it's machine learning. What we want is actually to integrate all the data together via some web services that are available, EDW, that occurs at MGH. But the next step that's very difficult for us is this right here. So remember the notes from clinicians that are very verbose and narrative? We need an engine or a way to actually transform that into more discrete values, more discrete concepts. And this is where, again, HealthShare can help out, which is the I Know product, a natural language processing tool that sits on top of the HealthShare product. We've already played around with that tool for pathology notes, and it works quite well. So from the pathology note, we can pull out staging, lymph nodes that are positive, the diagnosis, et cetera, and in a very discrete format. So the hope is with I Know, alongside with the discrete genomics information, we can actually now query for, give me all lung cancer patients at MGH whose age is less than 50, who has a certain fusion mutation, and what drug did they get put on, and what is the outcome that resulted as a result of the follow-up that we did in terms of intervention. So the whole purpose is actually to learn from the data and be able to represent it back out via a model so that we can actually affect patient management and therapy with a new outcome, a new knowledge association that we've discovered. So let me explain to you what we do today. So today, when we look at that one patient who has that one mutation that we found by genomics testing, the very first thing that we itch to do is actually go Google that particular variant and find in the rest of the world how often has it occurred. And then we look in PubMed and then other resources as well to see how often have we seen this mutation. Oftentimes, for something that's quite rare, the number is N of 1, N of 2, and at most what you get out from this literature is that there is a patient out there with lung cancer who had this mutation, but you have no idea what age, what's the sex, what treatment did the patient get put on, what was the outcome ultimately? Did they survive? Did they die within a year? We don't know that. So what we're proposing is actually to kind of short circuit sort of this, this method right here, but rather do this way, which is at MGH, we have that one patient who has that mutation. If we query HealthShare, we'll be able to find the other 4 patients who have been treated by 5 other different physicians. We're not well aware, right, who's doing what. Even inside a large hospital like MGH, it's very hard to know who is treating whom and who has what mutation, but by accumulating all that down in one system, we can find them. But the whole hope is that now we can say, oh, those 4 patients, what treatment were they put on? How did they survive? And what was the outcome? And then now that one patient in the middle that you're treating at this moment in time could benefit from prior experiences. So this is essentially saying we have knowledge in our backyard. We have access to the clinical information, the outcomes, as well as the genomics data. Why not use that? Why go to the outside when you have a much richer data set internally that you can have access to because you're improving the care of patients? You can actually use that information to benefit the 5th, the 6th, the 7th, the 8th patients, and so forth. But to be able to do this, we need a robust system, something that's fast, scalable, obviously enterprise level and interoperable. And I think that clearly defines what HealthShare is, right, in terms of a health information exchange system. But what we're pushing them to do is actually to support genomics data inside the same instance. And this is an arduous task, and we have been able to do that. The juncture we're at right now is that we have spec'd out the system and designed it to support the VCF files, the variant call format files. And what we're prepared to do now is load in our 5,000 patients and actually benchmark the system. This is a huge unknown for any EMR out there. And so we're hoping to do this over the next month once we surpass the security hurdles that have been put on, because this is patient data and we need to secure it before we move to the next step. And so with that, I will hopefully come back next year and tell you this in practice, which is the norm routine testing occurs in terms of patient genomics testing, but in addition to registering the patient into our LIMS system, in addition to registering them into the Epic EMR, which is what MGH is moving to, we would also register them into HealthShare. And HealthShare will pull in and retrieve all of the clinical data. Once the genomics testing is done, we also capture the outcome because of the NLP that we apply in HealthShare and put it into the same cube, the same indexing system, so that you have drug, treatment, outcome, patient laboratory values, the genomics results, all in one cube. And that's when you're going to push it through machine learning, logistic regression, linear regression, hidden forest, clustering, et cetera, be able to train a model, validate it in a clinical level with the rest of the patients that you have, and then redeploy this back into clinical production for decision making and support. So this is what I hope to come back next year, and maybe there may be 5 other people talking about the same thing, because I think we're pushing the boundaries here this year in terms of trying to do this. And so far we found that InterSystem HealthShare product has been viable to actually do this. So with that, I'd like to conclude to say genomics is quite complex. Making sense of the genomics variants really requires not just looking outside the literature, but also internally based on your own experience. And that setting up a system that can integrate clinical data with genomics information side by side not only benefits the patient, but also in general, the general practice of medicine. As we look forward to exome sequencing becoming more routine for every patient in a hospital, we're going to need some solution like this in clinical production.